One of the things I love talking about on stages now is that we should be looking at bone health as a biomarker of health span. If you're losing bone, something's off. I think this trajectory that we see mapped out for all of us as adults, I don't think it has to be that way because you see it, John, I see it. You can improve bone density as you age. So if that's true, then I don't think we need to accept this gradual decline. If you're losing bone, something's wrong. Sometimes you can't prevent it, and there are those cases. But if you have osteoporosis, if you're able to do the things that we're talking about, and we'll talk about in the next episode, if you're able to do these things, we should be able to see at least slowing down of bone loss, if not improving bone metabolism and improving bone density over time. I really think it's possible. We see it every day because we have such a large community of people that are doing it.
All right. Well, it's a real pleasure and a incredible honor to have two of the most important people in my life who can talk about bone health, Dr. Doug Lucas and Dr. John Neustadt. Thank you for coming. Welcome.
Thank you.
Yeah, thank you.
This is incredible. This is going to be the best episode ever that we've ever done in bone health. And I'll be referring a lot of people to this because your expertise, the two of you are both incredibly recognized leaders in both health, and you've helped thousands, probably hundreds of thousands of people navigate osteoporosis and osteopenia. So let's start with the big picture. I want to understand from both of your sides, what is the most misunderstood aspect about bone loss during menopause that women still aren't being told by their doctors? So maybe we'll start with, I see Dr. John, maybe we'll start with you first.
There are a couple things that come to mind. One is that when they go to get an evaluation and get that diagnosis, it's important to understand that 30% of cases of osteoporosis in postmenopausal women is because of things other than just the drop in estrogen. So ensuring they're getting a more comprehensive evaluation is really important for stemming that bone loss and reversing it. And then I would just mention one other thing that I think is important that is commonly misunderstood is that somebody does elect to take a medication. That change, the improvement in bone density, does not indicate that their fracture risk is decreasing. And that's often mischaracterized in clinical appointments. And it's important for people to have the facts.
I think this is a point I really want to drive home today, because there's many tests that we may take. And in my biohacking world, we're all about testing, measuring, and assessing and looking at numbers. And doctors themselves too look at a number and may make a prescription. And sometimes we need to take a little bit of a deeper dive, because just because maybe I have some high cholesterol numbers doesn't mean I'm going to have a heart attack. I don't know. I may not. And I think we need to take a deeper dive. And I think that's what we're seeing with our scans and the data that's coming out from, let's say, a DEXA. And it says, well, you've got a bad score. But I'm much more concerned about fracture risk. What's the likelihood that I'm actually going to break a bone? I don't care about a number. I want to see what are my chances of that? And that's really important. So we're going to take a little bit deeper dive into that on some of my other questions. I'm going to put a pin needle in here for that for later. But Dr. Doug, I would love to hear your opinion too on this question. And what do you think is the most misunderstood aspect of bone loss in this phase of life?
Yeah, so this is an area where I spend a lot of time right now. We're building programs for peri and postmenopause right now. And so we're literally creating all of the content around this. And one of the things that I really want to bring forward to the audience of potential patients and patients is the critical importance of imaging. You're kind of assuming, I think, in this question that somebody already knows their bone density, but the reality is that very few women are getting screened for osteoporosis, even though ACOG, the Menopause Society, the Endocrine Society, everybody recommends screening in perimenopause and as you go through menopause if you have risk factors, but most doctors forget about the risk factors part. Right? They don't ask the questions. They don't ask the family history the way that it needs to be asked to understand that. And from my perspective, I don't know a single woman going through menopause that doesn't have at least one additional risk factor. So I think that we need to be screening all women as they go through menopause for what their bone density is, if not to identify that risk, that fracture risk, but also every woman going through menopause should also be having a conversation about the risks and benefits of hormone replacement therapy. She may not be a candidate for it. She may not want it, and that's okay. But it is, estradiol specifically, is FDA approved for the prevention of osteoporosis. How do you know if you need it if you don't know what your bone density is? You're going into this conversation, and that's one of the biggest parts of the conversation, and most women don't have the data going into that conversation. So those are that's just one thing. There's so many things I could bring up, but that's one thing that I think is so critical, that if you have any risk factors at all, which I guarantee almost everybody listening has at least one or two, and you're a woman in perimenopause, fluctuating hormones, going through menopause, please get screened so that you can have a real conversation around whether or not hormones are right for you.
We discussed this actually in our first episode we did together, and I'll have a link to that in the show notes so people can catch up, because that was when I first was introduced to bone health and had so many of those just typical questions. And I learned so much from that episode, and I repeat this all the time. I remember you telling me, well, most people are covered for their first bone screening at the age of 65. And you've been working with people, with women in particular, who have osteoporosis, and they're only in their 50s, and it's actually too late by the time they get their first bone scan. And I mean, too late, meaning they've already been diagnosed with osteoporosis. We can reverse these very often.
Not too late.
What?
It's not too late. It's not too late.
It's not too late, yeah.
But it is too late to prevent that bone loss, right?
Yeah. And you're already there. And then I would like to have this discussion around the stress that comes with the diagnosis when somebody tells you you've got osteoporotic bones, and then the fear that happens when we think maybe I shouldn't exercise, maybe I shouldn't move. And this is where things can go really wrong. So I actually would like to talk a little. I don't know if you have anything to add to this, Dr. John.
I completely agree with what Doug said. And for me, I like to get a baseline bone density test when a woman starts going through perimenopause. I think that's important to get that baseline and then track it over time. And he's right. The most people who are eligible for bone density tests are not getting them done, and they should. Yeah.
And so the message is to get one, but you'd have to pay out of pocket. Is that correct?
Well, I'm not sure. I think it depends on the insurance and how it's coded and whether or not the physician can make a good case for it. If they can list other risk factors, and as Doug said, most women are going to have them. There's a long list of other diseases that damage bone and cause osteoporosis and increased fracture risk, autoimmune diseases, inflammatory disease, chronic inflammatory diseases, a long list of medications, family history. There's a case that could be made potentially to get that covered.
Yeah. But your doctor has to go to bat for you, and then they're going to refuse it, and then they have to go back and you have to do all the things. And it's hard. It takes time, and doctors are overloaded. I think it's worth it to pay out of pocket if you have to, because it's such an important piece of the puzzle as you go through that phase of life.
I agree 100%. And I have women in my community who have really fought for that and have been able to get their insurance to cover that. And so if anyone who's listening now, please have that conversation with your doctor and see if they can actually help you get that covered. And if not, okay, it is such an important tool. You did mention, Dr. Doug, about the estrogen as preventative to osteoporosis. And this reminds me of, I went to the European Menopause and Andropause Society just earlier this year, and it was clear, the research and the presentations, these are all researchers and doctors presenting, and they said the same thing. When we lose our hormones, we're higher at risk for osteoporosis and all these other things that happen. However, the guidelines, at least the European guidelines, showed that we are not giving hormones for prevention. We need to have a strong case. So she's have to have symptoms, or she has to have a strong case for that. So I'm wondering, how does a woman navigate who says maybe she's not even osteopenic, but I don't know, she's worried about her bone health and she may want to get on hormones? Is that, in addition to maybe many other things, as I know both of you talk a lot about, it's not just about the hormones, but how would you help a woman guide a woman through this? What would you say to her if she says, I want to prevent osteoporosis?
It is hard. I'm happy to start here. This is really challenging, not for me as a clinician, because I would just have the risk and benefit conversation and prescribe it. But for women who are finding it challenging to encourage or to have that discussion with their provider, if they are asymptomatic going through menopause and they're not meeting the traditional criteria for starting hormone replacement as she goes through menopause, it's a hard conversation because doctors have so much fear around using hormones. They've been trained. The bias is to use other things, even if they have symptoms, right? Well, let's use an SSRI instead. So what I encourage women to do is to just get as much data as you can and find the right team of providers who can work with you. Because what we know is that, yes, in the United States, the FDA has approved it for prevention, but our system isn't really set up very well to discuss prevention in general. So you don't almost have to, as a woman, go into your doctor's office and say, well, I have these risk factors. I have potentially even seen decline in bone health, and I would like to consider estradiol for prevention of osteoporosis. That would be a very totally rational conversation. And I bet there are still a lot of doctors who would still prefer not to prescribe under those circumstances just because of the amount of fear that many providers have around hormones, or they're just not trained in them, which would be that's the wrong person. But I think to take this a step further, here's what I struggle with, because I was actually listening to the Menopause Society meeting I think it was 2 weeks ago. And unfortunately, I wasn't able to attend in person, but I did get the recordings and I listened to all the bone health recordings. And the perimenopause prevention discussion was mostly about hormones and the importance of hormones. And the research that was brought forward demonstrated the improvement in bone mineral density in women with both normal bone, but also with low bone density and with osteoporosis. And so where I struggle with the recommendations is that very few doctors are going to actually use it for treatment. Clearly, it would be off-label. So hear me when I say that. This is off-label use. But for a woman that has osteoporosis, is it reasonable to consider hormone replacement therapy with or without potentially other bone health drugs? But is it reasonable under those circumstances if no other criteria are met? And this is the space that I really want to push into, because there are millions of women that meet that criteria that want to use hormone replacement for their bones, but also for their brain, also for their heart, also for potentially other symptoms. And they're being told no. And it's because the FDA has chosen really just to focus on the prevention, despite the fact that RCT after RCT shows improvement in bone mineral density with HRT as an independent intervention.
Yeah. Dr. John, any thoughts on that?
I think this goes to the point where people really need to become their best advocate and learn what they can and come armed with some facts and a little bit of data, because in this space of osteoporosis, it is undertreated, underscreened for, but also mistreated. And so in many ways, people I talk to when they read my book or I consult with them and then they go talk with their physician, in many ways, they're educating their physician, because the primary care doctors are typically the gatekeepers for screening and treatment. And they aren't trained to have the more nuanced conversations around diet and lifestyle. They're not educated in the clinical trials on supplementation. They're not experts in HRT in these situations, and they have very short appointments. They don't have a lot of time to be going through all of this. And what the research shows, if you do get your estradiol tested, that a level below 11, you're going to be experiencing bone loss. And when you replace the estradiol, when you get that up around 11 or above 11, that stops the bone loss, and the hot flashes, those symptoms decrease by about 50%. But when you get that estradiol up to 20 and above, that builds new bone, and hot flashes were 100% relieved. And just understanding a little bit of that and planting that seed with the doctor may get them to give it a second or third thought.
Actually, it doesn't take very much estrogen at all to get to around 20. It's like a baby dosage, and you could already start protecting the bones and squash a hot flash. And especially when I talk to women who are afraid of hormones, I ask them, very often, have you taken birth control? Of course. That was like, and when we compare the two, and especially we're talking about bioidentical hormones, it's like, this is so much less than what you were taking to prevent pregnancy. I don't think you should be so as worried about that. And if you're worried about cancer or some other problems, well, then let's look at the big levers, like the alcohol you're drinking, or then your obesity, or your smoking, or all these are the risk factors to me that seem so much bigger than just a tiny bit of estradiol that could help preserve the bone. I don't know if that makes sense or not, but that's the way I see it.
Yeah, I'd love to add one thing to that, Zora, which is in the studies, because I'm reading the same studies, and it is remarkable how little estradiol it can take. But what I've noticed looking at because I'm a lab guy. So I'm measuring everybody's labs on hormones, watching what's happening with bone turnover markers, watching what's happening with repeat imaging. And what I've found is that while the studies do show that those numbers are on average, so they're kind of picking the middle, there is a curve. And so I've used numbers in the past. There's evidence to support the idea of saying 60 to 80 picogram per ml is actually the threshold that you see in some studies. But I don't even think that's accurate for all women. I think there are microdose studies that show that a 0.025 milligram per day patch is adequate for a fair number of women, and that's going to give you levels kind of around what John just said. But then I also see the opposite true. And some women are having to drive it up higher. So we're also looking at these other biomarkers that is helpful. And this is where like your primary care doctor is not going to be probably willing to do this, unfortunately, but looking at what's happening with FSH, with suppression, what's happening with your CTX, looking at all of these things in a holistic picture to identify whether or not you're on the right dose of estradiol. And this is where it gets really tricky because so many doctors are against testing in general when it comes to HRT that most doctors are not going to go down that pathway, and they just put you on a low dose, you feel good, and then you don't know what's happening with your bones until you repeat your DEXA 2 years later.
I did mention that threshold of 20, and I agree with Doug that the research in terms of actually getting even better bone creation is higher. That 20 is the very bottom. My understanding, and Doug, correct me if you read differently, is that the optimal dose that I've seen is about 100, not dose, but blood test result is about 100.
100 picograms per ml, where we're talking about
picogram per ml. Yeah. And this is challenging in the hormone space because every country is different and even labs are different. Like LabCorp is different than Quest in the way they measure these things. It's so frustrating. So yeah, so picogram per ml, but 100 is not tolerated by a lot of women too. Like we can't get enough progesterone on board to balance it. That's not a physiologic static dose. And static's not physiologic anyway. And so it is a challenge. And this is why I consider this absolutely an art in working with a provider who understands how to do this through this lens of health span, longevity, bone health is important because you have to play with it a little bit to get the right dose dialed in at that level.
Yeah, 100%. I see that in my community too, when we're looking at labs or we're talking to women, and everybody's different. And I think this is also why it's so hard for me as a podcast host. Sometimes I want to pin down that menopause doctor and say, what's the number we should be at for X, Y, or Z? Right. And very often they're resistant because they see it's just so variable. We can say maybe for most women, maybe around that, or the research shows this, but the reality is that like in any study, we have outliers, right? You have people who respond differently. And so I agree 100%. This is such a fine art when helping a woman through her hormones to balance them or get them optimized. It takes, and I'm a big fan of testing and data as well, because sometimes you feel things and sometimes you don't feel things. And osteoporosis is a silent killer. We don't feel our bones getting brittle or a fracture about to happen. So this is why I think testing is quite crucial. So let's talk about the testing piece, because there's the whole DEXA scan that we can do, but then there's other things. And I've heard both of you, I'm going to have a link to this episode that the two of you did, which has inspired me to get you two on here. And you're talking about the DEXA and how it's a standard that we have. It's accessible for most people, but it has its shortcomings. So I don't know if let's maybe start with Dr. John first and what your thoughts about DEXA, any alternatives that we have.
All testing has its limitations, and the bone density test is still the gold standard. It's the oldest imaging test that's been around for looking at bone, and it's part of the original diagnostic criteria for osteoporosis is that T-score on a bone density test result. But it goes back to what you said earlier in the podcast when you were opening it up, and that is it's really about fractures. And any test from my reading of the research and looking at this issue is only as valuable and good as it is at predicting fractures. Now, that said, even if it's not a great predictor of fracture, I think there are reasons why testing should be done. And the main benefit that I see of testing is to monitor treatment and to see you're heading in the right direction. But also it can help motivate people and start the conversations and motivate them to take more responsibility and be more proactive for their health. So what we know with a bone density test, and this is not new information, was that in postmenopausal women with osteoporosis, it only predicts 44% of them will fracture. And interestingly, because fracture risk is not just about one number on a test, it's also about fall risk, strength, stability. A study was done 20 years ago that showed that if a woman's strength and stability was good, meaning their risk of falling was low, the bone density test only predicts about 5% of women under 70 who will fracture. So I think that one of the challenges is too often the number on the test is being treated and tracked and monitored, and patients are being told that they are protected when they're really not, or not as maximally protected as they could be. And there are other tests out there that could be run. None of them to date have been shown to be more effective at a bone density test at predicting fractures. And I know I could keep talking about this, as I'm sure Doug could too. I could talk for a half hour just about testing. So I'm going to stop now to give you a chance to talk. And I'm sure we'll go back and forth a little bit, maybe about other technologies as well.
Thank you. I want to mention, because you said only 44% will actually fracture of the women who get diagnosed with osteoporosis when she's in menopause. And that's a big number. And I'm wondering, I remember perhaps in your listening on your podcast, you had a story, I think it was about your mother-in-law or somebody who had been diagnosed, no diagnosis of osteoporosis yet had a fall and a fracture. Is that correct?
She was diagnosed. She was on Fosamax. She had osteoporosis and her bone density was going up. So she was happy. Her physician was happy. And I was happy. That's all I knew really at the time. This was 20 years ago. And then she tripped on a throw rug in her house and fractured her hip. And so I started looking at the research and diving into it. And that's when I discovered the limitations of that bone density test and started to reframe my entire approach around fracture risk and reducing fracture risk. And that bone density test is only one small piece of a much larger puzzle.
This is shocking. I mean, when I hear things like that, because we put so much weight. And when I first learned about DEXA, I was like, that's it, gold standard. That number is so important. And when I heard that, it really blew my mind. And also, Dr. Doug, you had a post or a reel I saw, and I just completely shared it across the board. And it was something similar where you said 70% or some big number of people who are diagnosed with osteoporosis will not have a fracture or something like that. Remind me.
Yeah. That statistic is, and statistics always depends on where they come from, but the reason why I like this one is it says that 70% of fragility fractures, there's a clear definition of that, but 70% occur in those without osteoporosis.
Yes.
Now, but the reason why that's true is that the population of women without osteoporosis is so much bigger than the population with osteoporosis. So it's sort of bastardization of the facts. But the reason why I use that statistic is that it puts forward the fact that DEXA and T-score are, as John said, not, they are maybe the best, but they are missing some of the detail that we need around fracture risk. They're only telling us what they can tell us. DEXA is a two-dimensional image. It is telling us about the density of the bone. There are add-ons to DEXA, Trabecular Bone Score, 3D Shapers, a new one that just got FDA approval that you can add on to DEXA that can give us more information, but it's still using the same data. It's still a two-dimensional image with pretty rudimentary technology. So we can only take so much out of it. The other imaging modality I know you want to talk about is REMS, and I talk about this all the time because we're just trying to get more information to help us to identify fracture risk. And so REMS, do you want me to dig into REMS here?
Yes,
so
maybe
talk about it.
Explain what REMS or REMS, that's what that is, and that technology, right. And so we can get a grasp on how that's different than a DEXA.
So REMS comes from the company Echolite. It's an Italian company, and they created this ability to use ultrasound. So the same ultrasound wand you would see when you go to your GYN, it looks like this thing that you put on your lower abdomen that you can see structures with. So same technology there. But what they did as this company, they're really smart engineers with ultrasound. And so they were able to create an algorithm that can then take that information that it's getting back as the wand images the bone, and it can give information from a 3D perspective because ultrasound essentially gives a kind of a 3D representation. it can tell us more about bone quality. It's telling us more about the things that are both mineralized but not mineralized. So you get a T-score similar to DEXA, but you're also getting a fragility score. And they actually have a new model that gives a strength score, which let's not get into the difference there. But it's giving you both the density as well as a representation of quality. And then it gives you a fragility score, which is a fracture risk score. So it is attempting to bridge that gap. The challenge around REMS is that while there are dozens and dozens, if not hundreds and hundreds of papers looking at REMS and the ability of REMS to identify to identify T-score, to identify fracture risk, it is well studied, but it is still not well studied enough to say that it can replace DEXA. We can only compare, and when something is considered as the gold standard, we can only compare something new to the gold standard. This is a challenge because DEXA has a relatively large margin of error. And the right term for that is LSC, or least significant change. Kim Zambito is a friend of mine, orthopedic surgeon, talks a lot about this. Dr. Nick Birch, same thing, orthopedic surgeon over in the UK, talks a lot about this. The least significant change is essentially the margin of error. Right. So the margin of error on DEXA, if you listen to the manufacturers, they're going to say it's between 2 and 3%. What that means is if your change in your DEXA, positive or negative, is within that LSC or margin of error, that we can't say that change is real. This is a problem when most people, unless they're doing a whole lot for their bones, most people are going to change their bone mineral density maybe 1%, 2% per year, plus or minus, hopefully, right? But we can't say that if it was 2% and the LSC is 3%, we can't say that's a real change. So we need a more accurate representation of what's happening with bone density even alone, but preferably with bone quality and with fracture risk. Now, the LSC, as it's been identified for REMS, is less than 1%, which is great, except that, again, it's newer technology. I don't think we know all the details we need to know around, does it need to be the same machine? We tell people with DEXA, go back to the same machine, the same operator if possible, right? The same person working the machine if possible, to eliminate as many variables as possible. We don't really know what that means with REMS. Because it's algorithm driven, because it's really, I don't want to say the wrong word here, I'm not a mechanic, not an engineer, but because it is driven by decision making behind the data, we think that maybe there's less chance, right, that it's going to have these variables, but we really don't know. And because I have so many people in our community, the Osteo Collective, that are getting these scans and bringing them forward and talking about their experience, people that I have some really awesome community members, and they'll literally go from one REMS to another REMS on the same day and get the same scan. And so we are seeing some, this is awesome. I love my community, but we are seeing some like unexplainable differences, right? One REMS to another, same day, same person. The only thing that's changed is the machine and the operator. And we do see differences in scans. So that's concerning that maybe it's not as consistent as we initially thought. I still think it's probably better than DEXA, but now I tell people more data better, get them both. I want to see them both.
Dr. John, do you have any experience with the REMS or thoughts on that?
I do. I think it's promising technology, and I think it has definitely some advantages over the DEXA, one being that it can be implemented in clinics for less cost than putting a DEXA in. And so we can screen more people. I do think it still needs additional validation studies. To date, I'm only aware of 2 validation studies that have been done because it is a relatively new technology. One showed that it was equally as effective at diagnosing osteoporosis or detecting osteoporosis. And the second one used the fragility score. And when I look at that data, I'm always asking, how well can it predict fractures? And so this is a study with about 2,000 women. It came out a couple of years ago, and it determined that a fragility score could predict, it had what's called the positive predictive value of 34.8% of women who will get a lumbar fracture and 6.3% with a hip fracture. Which from my point of view is not fantastic, but on a population level, if we can get more people screened, and again, one of the uses of technology and the benefits of testing is that it does provide the opportunity for conversations and to get more people involved in their healthcare. But what I think is one of the most promising potential things about this technology is with the fragility score. If it was less than 37.2, 94% of the women did not fracture their spine. And if it was less than 31.9 or lower, so 31.9 or lower, less than 32, 99% did not get a hip fracture. So it may turn out that the REMS might be better at predicting who won't fracture versus who will. And ideally, if somebody's fragility score is below those levels, below 32, they can start doing things to increase that fragility score. But one of the limitations of the current data is we don't have data that shows that if you can decrease that fragility score from a higher one, does your risk of fractures go down? That just data has not been collected yet, and I'm interested to see that.
Dr. Doug, you've seen a lot of people with these REM scans as well. And I'm not sure, Dr. John, if you have as well, but I'm wondering, the fragility score seems pretty important because like we said, and fragility, I could be making a mistake. I could be associating it with a fracture score. Yeah, I'm kind of making my own interpretation, and maybe that's wrong. But I'm thinking, oh, this is a great add-on, and it seems as though I would like to know if Dr. Doug's, if you see people showing REMS versus DEXA, if they're both in osteopenia, are they both in osteoporosis, or do you see a lot of variability where REMS says osteoporosis and DEXA says osteopenia? You see any variability with that?
Yeah, unfortunately, yes. And so these are the challenges, right? So we have people who have, and I've had patients in this situation, very low T-scores on DEXA. I'm talking -4s, -5s. They get a REMS and their T-score is -1.
Oh, wow.
I mean, it's profoundly different.
That's huge.
And so then, of course, they're calling me, right? They're like, what does it mean?
Am I free?
And of course, you want to believe the better one, right?
Yes, of course.
But what I tell them is, look, these are two different technologies. They're looking at bone in two different ways. You can't ignore either one. And so I think usually they're more concordant. They're similar. But, and I have something on discordance in a second. But when they are different, I don't think that we can just choose the one that we want to follow and follow it. I think we need to really, at that point, you're kind of obligated to follow both. But I will say where REMS becomes very helpful is with those numbers that John was saying. If they have, especially our small framed, like yourself, Zora, Caucasian, Asian women who have small bone frames, who have what seems to be a low, maybe not well represented low T-score, and then they go and get a REMS and their fragility score, you mentioned those thresholds, John, but I've seen these fragility scores in the teens and single digits, right? They have very good looking bone quality. And their doctor was going to put them, of course, their guidelines are you need to go on an anti-resorptive therapy. So they were very happy to say, well, maybe I can push this out. And I say, well, maybe. We still can't, I can't say with certainty that you're not going to fracture. But this is great additional data to support the idea that maybe you have time to continue to work on your bone health. So I think it can be really helpful there. The other thing I want to point out, and this was a study that was published by Nick Birch, a friend of mine in the UK, and he has a clinic, bone health clinic, and he has done thousands, and he has this amazing database of all of these REMS and DEXAs and all of these bone health patients. And so he did a study on his own data, and what he showed is that there's less discordance, and I'll define that, but there's less discordance with REMS, which is promising for me. Discordance means a change in more than one standard deviation from body part to body part on a scan. So you've seen this a lot, I'm sure, Zora. So someone who comes in, they have quote unquote osteoporosis of their spine, but they have normal bone density of their hip. And they're like, how is that possible? Well, I think there is some potential regional variation, but this is a systemic disease. So it would be odd to be 2.5 standard deviations lower on one body part than another. And there's more discordance on DEXA than there is on REMS. And so this is, again, why I think REMS is probably doing something different. It's doing something, I think, better. But like you said, John, we need better studies, and we need studies not done by Echolite. Not that they're not doing good studies, but we need studies done by third parties to further validate this so that we can use it, I think, responsibly and confidently in the clinical setting.
Yeah, 100%. Actually, it reminds me when I had my DEXA, I don't know, maybe 2 years ago, and you saw me sharing on my Instagram story. You said, let's interpret this together. Yeah. And to my surprise, I had osteopenia, and it was a surprise and not a surprise. And you did a great job in interpreting that and explaining what that means, because I had great DEXA scans up until then. But it was interesting. I was sent home by the doctor saying, just take some calcium and walk. And I thought, gosh, I don't think that's going to be enough. And actually talking with you, it definitely was not enough. And this is part of the problem, is that here's a woman going through menopause and she has low bone density, and you're just going to send her off with calcium and go for a walk. And that's not going to be good enough. But then since then, I've done the REMS scan. And for a year and a half, I think, I was thinking this is horrible because I had osteoarthritis, which is a whole other story. This is a joint disease. And it kind of made sense to me. I was like, well, I haven't been moving because of the osteoarthritis. I'm on baby dosages of hormones, and I haven't optimized those yet. And so perhaps this could be true. But when I took the REMS scan, it validated the DEXA. I had actually, my hips were great. It was my spine that was a problem, and I had hip osteoarthritis at the time. So when I got the REMS scan, and the fragility score was great. I don't remember what the number was, but I do remember being told I have the bones of almost a gymnast. And that was pretty good. So it felt like the weight taken off my shoulders, because it is scary to have this diagnosis, even knowing I can reverse this. I have all the tools. I knew once I got my hip operations, I'd be fine. But still, it hurts. But what I did like about the REMS that I took was with Screen My Bones, and they gave me a bunch of information on, okay, you maybe have a good fragility score, but you still need to test your minerals, or to make sure you do exercise, and make sure that you do impact and you eat the protein, and yada, 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 a whole protocol. It wasn't just, okay, go home and walk and get some calcium. So I think I'm hoping that the REMS will be validated. Again, we don't know, and we're in this space, because it did give me a sense of relief. I'm still doing everything I need to do. However, when a woman is getting these diagnoses, and you see this all the time, how the fear in her eyes, like, what do I do? Whether it's osteoporosis or osteopenia, are there any other screening tools that she can use outside of DEXA or REMS that would validate perhaps what she's seeing in those scans? I don't know. We'll go with Dr. Doug first, and then see Dr. John what we have.
So from an imaging perspective, the other thing that we talk about is CT, but CT is not a good tool to use on a regular basis. It's just too much radiation. And so this is more of a research tool. I have had patients who've actually pursued this. Again, I have an amazing population of people that they want a lot of data. But I don't encourage CT because, again, you don't want to keep repeating CT over and over again. So then that leaves us with, what are the things that we can add on? I kind of mentioned briefly the trabecular bone score. This gives us additional information on top of DEXA. 3D Shaper, I think, is interesting for hip architecture. That's a new one, and I haven't looked a lot at the research there, but I did an interview recently that'll go up on my YouTube channel probably in the next few weeks on that. So I just encourage people to get as much data as possible, but then also to recognize that it is limited in what it's going to tell you. So I find so many times, especially just the mindset of especially postmenopausal women with osteoporosis who feel trapped and scared about the medications, is they want a concrete answer, and understand that we can't give them one. There's no imaging study that's perfect. Even you could say, well, I want to get an MRI. Well, it's still not going to tell you what your fracture risk is. There's just too many variables. And so we take it for what it is, and then we move on and we create a plan. Let's get the data that we can get. I also get bone turnover markers, blood markers, all kinds of biomarkers. So we can get this data. We can look at genetics. Like, all this stuff is valuable. But then we create a plan, and then we move forward, and then we keep retesting to make sure that we're heading the right direction. And that, I think, is the takeaway for me from imaging, which is, let's use it for what it's good for. Let's get the information out of it that we can. Let's identify the fracture risk to the best of our ability, but recognize that it's really not that good, and then move forward from there. Let's create a plan. And the best part about that is that all of the things that are good for bone health are good for health span across the board, right? The things that are good for your bones are good for your brain, are good for your heart, are good for your longevity. So there's really no downside here. Let's just get to work and let's do the things.
You mentioned a trabecular score and a 3D shaper. Are these worth getting? Or are you just going to say, hey, let's just get the DEXA again or REMS again?
So I'll give you a little bit more about trabecular bone score. TBS has been studied extensively, right? So there's a lot of research on TBS. TBS gives you a number which you can measure from scan to scan. So I think there is value in that. But the reason why I don't love TBS is that it really breaks down people into one of essentially 9 groups. It's a 3x3 grid. So either you have normal bone density, low bone density, and osteoporosis, like normal, right? And then the other grid is you have normal bone quality, you have partially degraded bone or degraded bone. So it's a 3x3 grid. Most of my patients and community members have osteoporosis and partially degraded bone. If the test tells me the same thing every time I send somebody to get it, it's not really particularly valuable for me. Now, where it is valuable is if someone comes in and they're an outlier, meaning that let's say they have low bone density, but they have degraded bone. They have the worst quality bone on a TBS. That's actually of interest, right? So now you're saying, ooh, maybe your density is not bad, but your fracture risk might be higher. So if they have access to it, then sure, get it. If the DEXA machine that you're going to can give you a TBS score, awesome. Let's get it. Again, generally more data better. 3D shaper, I don't know enough yet. I think it's interesting. It doesn't work for the spine. It only works for the hip. So I look forward to learning more about that technology and seeing that potentially being pushed forward. It sounds cool, but again, it's very new.
Dr. John, yeah, what do you think about these extra tests, and are they worth doing?
When I was on, Doug had me on as a guest on his podcast. I remember we had a very interesting conversation about testing and where we both fall on testing. I think I use testing less frequently than he does. I do think there's value in helping people focus and making some clinical decisions, but ultimately there are very few tests that have really been validated for, meaning if the markers change, is your fracture risk decreasing? Yeah, there are only 2 bone turnover markers, for example, that are recommended by the International Federation for Clinical Chemistry, and that's CTX and P1NP. And yet there are many other bone turnover markers that clinicians are testing, like undercarboxylated osteocalcin, DPD, NTX. I mean, there are about a dozen of them, and there's no standardized reference ranges. Most have not been validated. And so for me, it's just, I prefer if people want to spend that money because it's going to help them to focus, that's fine. But I would prefer they spend that money on healthy diet and exercise and doing things that we know will reduce their fracture risk and improve their bone, not just quantity, but it's bone density, but the bone quality as well, and decrease the fracture risk.
Yeah, this whole fracture risk thing, I want to wrap this up and then go on to supplements and what we can add on to our diet and lifestyle. But the question about, there's a statistic that we all quote and we all hear it all the time, and it's very scary. And it's that the 30% chance of dying within 6 months if you have a fracture after a fall. And usually we're referring to people over 65. But I also understand that this number, it can be up to 30, but it's also more relevant to people who are frail and not those who have good bone muscle mass. So if you tend to, and it doesn't mean somebody, when I picture somebody frail, I'm thinking them very thin and weak, but actually, evidently, it can be somebody who's overweight. So this statistic I've heard really applies to those people who are frail. Is that true, or am I just wrong, misinterpreting it? I don't know, Dr. John, if you know probably a lot about this statistic that I'm talking about, right?
So in terms of the overall fracture risk from a hip fracture, which is the greatest risk of dying, the greatest risk is with a hip fracture. And the statistic that you cited, it's up to 36% of women 65 and older who fracture a hip. And the studies really go anywhere from like 20% or 20, the most often cited is 20%. I think it's as low as about 10% up to 36%. So it's a big range. And yes, the frailty, comorbidities all increase that risk. I've never seen that stratified based on those definitions of comorbidities or frailty. It's just, I've only seen that. Doug has seen it presented differently. Risk stratification based on frailty and other comorbidities. But frailty, gait, and mobility is the most consistent predictor of fractures. More consistent than any test, more consistent than anything else. And so making sure somebody is, again, as I mentioned before, strong and stable. What can we do to do that is an important way to reduce somebody's fracture risk. And if the exercises are weight bearing exercises, also to improve bone density and bone quality.
Great. Dr. Doug, is there anything you'd like to add to that, or we're going to move on to supplements?
Yeah, I'll just mention it briefly. It's funny, this actually came up in our community town hall today. Someone was asking about the statistic because everybody who talks about bone health uses this statistic. And so I agree, I've never seen it actually stratified. But what I can tell you is clinically, as an orthopedic surgeon practicing and treating these fractures, is that the patients who died, who I followed until death, that mortality, they generally were older, they were more frail. Right? They don't have a reserve to be able to tolerate laying in bed for the couple of days that it takes to get them mobilized. The factors that make this worse are going to be if they are predisposed to like urinary tract infections, which can become sepsis. If they have a propensity for developing pneumonia, right? If they don't have great cardiometabolic reserve, those things are going to predispose them to not do well after that fracture. Not because there's anything wrong with the surgery, but surgery itself is trauma. The fall is trauma. Anesthesia is trauma to the brain. So going through that process, getting the surgical repair so that we can mobilize them, puts them in a situation where they do not have the capacity to recover. So I think that's important. The second thing I think that's important here that you mentioned briefly is that it's not all elderly, frail, skinny women that die from a hip fracture. I did see, and these were the hardest cases, the obese older women and men for that matter, who would have a fracture. And obesity, in some ways it kind of works with bone health because of the additional load, but in other ways it doesn't because of inflammation, oxidative stress, hormone dysfunction, et cetera. But once you are disabled from a fracture and you're recovering from surgery, it is nearly impossible to mobilize those patients. So then they end up struggling with bed ulcers, infections. Those are the things that's going to kill that patient population. It can be very difficult to treat. So while it was almost predictable who actually would die within those next 12 months, the part that was most troublesome for me is the loss of independence that occurred from those fractures, because we did see that on a regular basis, people who just never got back. And that's the bigger statistic. When I say the 30% statistic, I actually really lean on the other side of that, which is 50 to 60% of that same group, not the 30% that died, but of those that didn't die, 50 to 60% or more will lose their independence. And that, I think, is the bigger tragedy.
Yeah, that makes perfect sense. So we've got about 5 minutes. And I have another hour. I want to talk to you guys about this, but both of you have books out that are incredible, and everyone should go and buy this because you go step by step on what we need to do to reverse osteoporosis. And you both have podcasts as well. So there's just loads of information here. And you do talk a lot about this foundation that we all know we need to get in terms of diet and exercise and sleep and stress management and all these things to improve our bone health. So with that being understood as a caveat, before we talk about supplements, because the problem is when I say supplement, everyone's going to say, oh, I don't need to do all these other things. I'm just going to take supplements, or I'm just going to take hormones. And we're not talking about that. We're assuming that you're doing all the things that these doctors would love you to do. But when it comes to supplementation, and if we test ourselves and see we're deficient in certain things, we think, okay, let's get on a supplement. It's an easy thing to do, but there's so many bone supplements out there and it can be confusing. So would love to hear your thoughts. And we'll start with John, because I know you know a lot about supplements too, and you shouldn't have your own formulations, but I've heard of things from algae to vitamin D, magnesium. There's the K2 question that I want to talk to you about as well, and strontium. These are ingredients you'll very often find in bone supplements. So I'd love to hear your take on what is worth looking at, or what we should look for in a supplement or not, or what should we do before we take supplements.
Before you go, John, let me say this about my book. So my book needs to be rewritten. So it is available on Amazon if you want to go buy it. But actually, Zora, what I think we should do, we've done a quick edit of our ebook. So I think I should just give your community access to the ebook. And so we'll just let you guys download it. So that'll fix the editing problem. It needs to be further edited. It takes so much time. John knows it takes a lot of time to write a book.
So the second edition right now of mine.
Yeah, so that's coming, but mine, we've just essentially turned it into a resource for people because I just want people to have it. So I'll get you the ebook version, Zora, and then let's give this enough time. Let's go at least another 10 minutes after the hour so that we can get through at least three of the things that you talked about.
Okay. Yes.
Supplements is a big topic. I do want to say then, Doug, and that's very amazing offer for her community. I would like to extend the same offer then with my second edition of the book. I'm editing the layout right now. So we've got a little bit more in terms of production, but I've already got the PDF and we're in the first round of edits. So that should be out hopefully before the end of the year or Q1. And we can provide an ebook for free for your community as well.
Thank you. We'll have links to that in the show notes, but it's commendable to you guys who are always on top of the science and realize that things change, science changes, and you as well, your experience does as well. So I appreciate that not only you've offered this, but that you are spending time revising your own content. So thank you very much. Okay, Dr. John, let's tackle this supplement question.
Yeah, this is a big issue. Obviously, it's a $70 billion industry, the dietary supplement industry, and there are lots of formulations for bone health out there. When I was looking at this issue 20 years ago, and I still look at it through the same lens after my mother-in-law broke her hip, I started asking the question, what nutrients have been shown in clinical trials, not only to support healthy bone density, but maintain bone strength? And the best indicator of strong bones is that somebody doesn't break a bone. So which nutrients have been shown in prospective clinical trials to reduce fractures? And there are only 4 that met that criteria at the time. And there are only 4 that still to this day, 20 years later, meet that criteria. Not that there aren't other wonderful nutrients that people could benefit for, but when I'm just targeting bone health, I'm very specific and very narrow in my recommendations based on how I am looking at the research. So those are calcium and vitamin D. Those have been shown in clinical trials to reduce fractures by about 18 to 23%. And I do think it's important to test vitamin D. The maximum fracture reduction, hip fracture reduction, is when vitamin D was 30 to 44 nanograms per milliliter. Obviously, for other immune function, we want it to be higher, but that's just for bone health. And then the average person can get to that level by taking about 2,000 IUs of vitamin D3 a day. The other 2 nutrients are a specific form of vitamin K2 called MK4. Many people have heard of MK7, but vitamin K2 is a category of nutrients. MK4 and MK7 are 2 of them. And MK4 is the only one shown in clinical trials in the dose of 45 milligrams per day in divided doses to not only promote healthy bone density in postmenopausal women with osteoporosis, but to maintain strong bones as indicated by over 70% fewer fractures in clinical trials. MK7 is more popular. It's in many more dietary supplements that are out there. All the clinical trials on PubMed for MK7 show that it only slows down how fast somebody loses bone density. It's never been shown to stop bone density in those studies or increase it. And in fact, one study of a high dose MK7, I think it was 320 micrograms per day. In that study, the women taking it lost bone density at the hip faster than women not taking it. And in addition to that, there are no fracture outcomes data on it, none. And
well, then why are they using MK7? Why don't all bone products use MK4?
A few reasons. One, I think that there is an economic reason from manufacturers, and myself being a manufacturer, owning a brand. The MK4 raw material is a lot more expensive to manufacture with. It's not a commodity on the market. It's a very specialty niche nutrient. And MK7 has a longer half-life, so you only have to take it once a day. And so they market it as being more convenient. It changes one of those bone turnover markers I mentioned under carboxylated osteocalcin. All forms of vitamin K will do that. K1, MK7, MK4. But back to the story that a laboratory test or any test doesn't necessarily mean that your fracture risk is being reduced. Just reducing that marker doesn't necessarily mean it's being reduced. Vitamin K1, for example, there have been clinical trials. It'll reduce under carboxylated osteocalcin, but in the fracture outcomes data, it did not reduce fractures in osteoporosis or improve bone density. MK4 is the only form of vitamin K that's been shown to do that.
Okay.
And the other nutrient is strontium, but I'm not a fan of strontium. I recommend against it, in fact, for several reasons. All of the clinical trials on strontium are done with strontium ranelate, which is approved as a medication in Europe. strontium citrate as a dietary supplement is what's available in the US. There are no safety or efficacy clinical trials on strontium citrate. So the manufacturers basically are taking the research from Europe from strontium ranelate and saying, well, we just believe it's going to be equally as effective. Well, if they're doing that, let's look at, first of all, what the fracture studies say with strontium ranelate. But they also then, to be honest, I think, and faithful to the research, need to also say, well, we have to assume that it's equally as safe. So what did this say about both of those? So there have been 5 large clinical trials on strontium ranelate. 4 of the 5 showed it only reduced vertebral fractures, not hip fractures. So whether it reduces hip fractures, the most dangerous type of fractures, it doesn't look like it, at least in most clinical trials. And it reduced the risk of vertebral fracture by about 45%, which is the same as Fosamax.
What about the Fosamax?
Fosamax.
Oh, that's the medication.
Oral
Yeah.
bisphosphonate.
Yeah.
Correct.
Yeah.
And then the safety data, it was taken off the market for a while in Europe, and now they have to have cardiovascular risk assessments before prescribing it, because in post-marketing surveillance research, they determined that for every 1 fracture that was prevented, it also created a blood clot that could cause a stroke, DVT, heart attack. And so again, with the strontium citrate, there are no safety studies on it. There are no outcome studies on it. And strontium also causes false bone density test results. Now, people can say, well, we know maybe it changes it by about 10%, so we can just adjust in our head. But for me personally, I'd like to get my bone density test results as accurate as possible.
Okay. All right. I still have questions, but I'm going to let Dr. Doug talk because we have such a little time.
Yeah, no, it's great. John, you do such a great job of explaining this. I don't have a whole lot to add to that other than my approach has been different, although actually our conversation did change it a little bit. And then recently, John, you and I, we were talking about the new edition of your book, and that spurred me to take a second look, or I don't know, a 10th look at the products that you make. And so actually right now we're creating some new we have an algorithm on if this, then this blood test, how much you eat, what products to take kind of thing. We're actually creating some new lines of that with different ideas on how to incorporate the NBI products that John helped to formulate. And the reason for that is that there are not a lot of products that use that 45 milligram dose of the K2 as MK4. I have been in the camp of using MK7 for the reason that John stated, which is has a longer half-life, it's easier to dose. And then the other reason why I lean toward supplements that are replacing, well, take a step back. I generally kind of group supplements into 2 buckets. So I look at supplements as replacing something that you would be getting through diet naturally. So this would be like, assuming we could get vitamin D through sunlight and diet, how much are we going to replace? What he said, 2000 IU, to kind of a sweet spot for a lot of people. Same thing with calcium. How much calcium do we really need? If you're getting it through diet, you're not getting enough. Okay, let's supplement. How much do we need? 200, 400, 800, whatever that is. When I look at K2, you kind of have 2 different choices here. K2 as MK7 is often put in products around that 100, 200, 300 microgram dose. You would have to eat a lot of aged cheese to get there, but it is possible to get that much MK7 through diet. The 45 milligrams, and to be clear with the units here, there's 1,000 micrograms in a milligram. So the K2 as MK4 as 45,000 micrograms is what I consider a different bucket. This is the super physiologic dosing, right? And we do this with all kinds of things. So I'm not saying this is dangerous or bad. I'm just saying it's a different approach, right? So we are now using something as a tool in a different way. This is you could never eat that much K2 as MK4 through diet. But the research is really clear. And I had read these studies and John just pointed them out to me again to say, look, these were big randomized clinical control trials. They were well done, well studied, repeated, and showed these very powerful benefits. So it makes sense to use K2 as MK4 in these, what I would consider super physiologic doses. The question I have that I would actually love to ask you, John, is how long should we take these super physiologic doses? These studies weren't that long. Are you recommending people to take this? Is this indefinite, or is this just until they have normal bone density? This is where I don't know the answer to this right now, but I agree with you. I think that it is probably one of the best studied forms of vitamin K.
That's a great question, and one that I get not that infrequently. The longest clinical trial was 3 years. So there are various ways that I can answer this. The longest clinical trial was 3 years. No adverse effects. It has been approved since the 1990s in Japan by the Ministry of Health for osteoporosis and bone pain caused by osteoporosis. Now, in the United States, it's not a drug. It's a dietary supplement nutrient. It's not approved by the FDA to diagnose, prevent, cure, or treat any disease. But what it does is powerfully pushes the biochemistry and the physiology in the direction of bone creation and maintaining bone strength. In Japan, in the package insert, there is no warning that the medication in Japan, the MK4, same dose, 45 milligrams per day, needs to be discontinued after a certain amount of time. And so has not been identified as a risk in Japan. In the United States, the National Academy of Medicine there's no tolerable upper limit set for MK4, meaning we don't know the toxic dose. There's no upper limit that's been set. We do know that it is safe in the dose taken, been up to 135 milligrams done in cancer clinical trials with no adverse effects. And the LD50, the lethal dose that will kill 50% of the experimental animals, which is how toxicology studies are conducted, is kilograms per day. I have had people, my first product, so you'd have to be eating way more than what's in any of my products. The first version of my bone support line, OsteoK, came on the market in 2007 or 2008. I think it's 2007. And then I've got two other versions based on the amount of calcium, one with no calcium, one with lower calcium, all with the same D3 and MK4 dose. And I say that because there have been people now that have been on those products for 10, 12, 15 years and still taking them. And from my point of view, do you take that until your bone density normalizes and then do you stop it? I don't know the answer to that in any definitive way, except for it's a judgment call. It may end up being similar to hormone replacement therapy, where if they stop taking it, the bone density may start going down again, or similar to other interventions where we see if they stop doing it, the bone density begins to decrease. I don't know, but we do know that it's safe for very long term. And I know for my own family, my mother-in-law, she just passed away this last year at 93 years old. She was on it since I created that first product in 2007. And it wasn't the OsteoK that killed her.
I think it kind of almost boils down to just test, measure, and assess and see how you're doing. This is what I would do if it were me. I'd probably be on a supplement. And then after a while, we all get pill fatigue, or we all just like, oh, let's just stop this and then test. And if my bone density is going down, well, I just get back on this. Now, whether that's the right or wrong approach, I don't know, but that's sort of the little biohacker in me thinking, let's see what happens, but hopefully not at a risk of a fracture and all that. It probably depends on a case by case basis and how bad you are. I don't know if Dr. Doug, do you have any last thoughts before we wrap this up?
Gosh, we could do a whole episode on supplements. No, I think that John says it really well. There's some other things that I like to talk about. Boron is a fun topic to talk about, just an interesting compound. I don't even know what to call it. It's like kind of a mineral, but kind of not. So yeah, I think we should probably do this again at some time and talk more about these things. But those are the big picture things when it comes to supplements. It just needs to be customized. There probably isn't a perfect product for everybody. And this is why we have multiple verticals of different tools. And this is why, John, how many bone health versions do you have? Is it 3 or 4?
3.
Yeah, 3. Right. So everybody's different. And that's the most important thing, I think. And people hear me talk about Algical. So like whether it's the Algical line, of course, and I agree with John, like I'm not a fan of strontium either. So whether you're thinking like Algical Plus, or you're using the NBI products, or you're working with somebody else and they have their own product, like whatever it is, just make sure that the things that are in it are right for you, because everybody's needs are different. There are some overlap, right? There's some things that are similar, but everybody's needs are different, and you're going to be getting them from different places. We all eat different diets. So this is one of the areas where we're pushing into more and more, is how do we customize these supplement protocols for people so they understand why they're taking it, how long they're going to take it for. That's why I ask you that question. What is the outlook here? Do we need to rotate this, add in something else, switch this for this? It's so complex. I hear you talk about it all the time, Zora. It's so complex because we have so many different goals. But yeah, we don't need to add anything else to that now.
Okay, we're going to have a part 2. if you guys agree to come on, I've got about 10 more questions and we can talk over and over and over about this. And I love that we also have our communities and we can share exactly what we're seeing. And this is the real life. So if anybody wants to learn more about Dr. Doug Lucas, you can go to osteocollective.com and you can find also a lot more about Dr. John Neustadt on his website, nbihealth.com. You'll find his podcast there as well. The book will have the links in the show notes, and check out his supplement line at nbihealth.com. And if there's anything else that I've missed out, Dr. John or Dr. Doug, speak now or forever hold your peace. Anything else you'd like to add, Dr. John?
I just want to say one of the most important things that I often see missing, even when everybody seems to be doing the right thing, is they're not consuming enough protein. And so making sure you're getting enough protein, and I like the recommendation 0.6 grams of protein per pound body weight per day minimum. Your body needs those raw materials to create bone because bone is highly protein dependent. There are over 180 to 200 proteins in bone. So diet cannot be, there are no shortcuts. It's not just take a pill and everything's good. The diet, exercise, lifestyle, it all works together.
Yeah.
We're going to cover that in the next episode, right, Dr. Doug?
Yeah, maybe we'll hit the lifestyle pieces next. No, I totally agree. Use a slightly different number, but I agree with that threshold. That's the minimum, right? 0.6 grams per pound. And I think all the lifestyle pieces are critical. I think the most important thing is to just don't lose hope. What I have found to be most impactful for me is that, again, through our YouTube channel, we have hundreds of thousands. Actually, well, I guess we've had, I don't know, like 8 million views, right? So we get all of these stories. People are just so generous with their story on YouTube. They literally, in a comment, will just tell me their entire story. And it's amazing. But what we can tell from the YouTube channel, from our community and our clinical practice, now seeing thousands and thousands of people go through this bone health journey, is that for the most part, with rare exception, I think osteoporosis is preventable. I think we can stop that bone decline. One of the things I love talking about on stages now is that we should be looking at bone health as a biomarker of health span. And we could actually do a whole episode on that, Sora. But if you're losing bone, something's off. I think this trajectory that we see mapped out for all of us as adults, I don't think it has to be that way because you see it, John, I see it. You can improve bone density as you age. So if that's true, then I don't think we need to accept this gradual decline. If you're losing bone, something's wrong. Sometimes you can't prevent it, and there are those cases. But if you have osteoporosis, if you're able to do the things that we're talking about, and we'll talk about in the next episode, if you're able to do these things, we should be able to see at least a slowing down of bone loss, if not improving bone metabolism and improving bone density over time. I really think it's possible. We see it every day because we have such a large community of people that are doing it.
Thank you so much, both of you, for making the time to speak to our community. And thank you for the listeners who've reached to the end of this podcast. I know it's so juicy, right? And I'm super excited to have a part 2. So thank you, everyone. Have a wonderful day. Good night, good morning, wherever you're at. And I look forward to seeing both of you next time. Thank you.